Today we talk about multiple sclerosis and MS is such a challenge. तो ज़िंदगी में बहुत कुछ हमको सामना करना पड़ता है. It's unpredictable. But I think MS is a truly unpredictable disease in ways more than one, because it affects that age of population where you don't expect these things to happen. You expect them to happen when you age. And there are a lot of things which you say कि अच्छा तो उम्र बढ़ गया है तो होता है ये. You know, you take blood pressure, you take diabetes, you take so many other things, and there are situations where, you know, you forget and they say कि तो बुढ़ापा है तो भूलेगा ही. There are a lot of stuff which you attribute to an aging process. And there are systems where you think कि ये तो बहुत छोटा है, ये तो, you know, when you're growing up, there are problems. But young age में, you're 16, 17, 20, 25, 30, 35, 40, you're in the prime of your age. You don't expect things to happen like that. You don't have risk factors, you're not a diabetic, you're not hypertensive, you're living life to the fullest. You have a healthy lifestyle, you're going to the gym, you just passed your graduation, you're getting into your post-graduation, you finish your studies, you got a great job. You found your life partner, you're getting into marriage, or if you're married, you're looking at a childbirth. That's when this disease is striking. So we thought that unless you get the knowledge of awareness about what this disease is and how you can live with it and live happily with it, control it, overcome it, you know, that I thought was absolutely, all of us feel as people who have been working with MS, and we don't call them patients, you know, that we call them people living with multiple sclerosis. So that is the exercise again. There is always a theme every day, every year, and this time the theme is connections. So the connections essentially don't mean ki what are those intricate, complex connections in the brain. Halaki, you know, now the brain is called a huge connecticome. You know, this thing about understanding what brain is also has evolved immensely, and it is absolutely exciting to enter this era where we are trying to understand what nervous system is all about. Rewriting anatomy and physiology and rewriting the functional aspects of. Now we know that whether we laugh or we cry or we feel depressed or we feel love and affection or anger, everything is in signatures in the brain. And it's probably determined by a little bit of a structure and a bunch of molecules and neurotransmitters. It makes it less glamorous, but it helps us understand how we function as human beings. So therefore, these connections, yes, are important within the brain, but what the theme essentially means is connecting to each other, connecting with the society, holistically empowering ourselves by connections to be able to understand and overcome the challenges that MS may give us. Okay, so that's a theme as such, but what we thought that we will modify it and we'll make it into something called, you know, all what you want to know, or I must say all what you need to know about multiple sclerosis. So that is the main thing, and I'll give you a very brief overview. I won't bore you for long. Then subsequently we have Professor Rohit Bhatia. He's actually a national champion for multiple sclerosis. Proud to have him here. And you know, I think all of you know him. In fact, I must introduce myself because a lot of you don't know me. I'm Padma Srivastava. I'm the chief of the Neurosciences Center. And that's Professor Rohit Bhatia. And that's Dr. Ayush Agarwal, who's our faculty in neurology. And that's Dr. Ela, who's also faculty of neurology. We would have more people up there, but this actually has come in the so-called official vacation time. So there are some who are not in town, but it's okay. We can make up. Okay, so that's MS. So what is multiple sclerosis is, I think all of you know about it, but for some who just came in here for general awareness, now this is an autoimmune disease. कोविड से पहले द ऑटो इम्यून बोल के जो टर्म को लोग नहीं जानते थे, बट नाउ विथ कोविड ऑल ऑफ यू नो, इजंट इट, दैट इट इज समथिंग टू डू विथ इम्यून प्रॉब्लम. COVID actually has really, enhanced our knowledge about immunity in general. Now, what autoimmune essentially means is that our own cells wage a war against our own system. So it is not something from outside which is, waging this kind of war against us, but it is our own system. That's why it's called autoimmunity. And there are a lot of autoimmune diseases in the body. Very famous amongst them is rheumatoid arthritis. A lot of you must have heard about it. And MS is a variety of autoimmune disease which is relegated to the nervous system. When I say nervous system, it is brain and the spinal cord. So essentially, again, the autoimmunity is tailored towards the covering of the nerves or the white matter. Broadly, it has much more than that, but broadly what it does is it strips off the protective layer as well as the layer which is responsible for passing the electrical signals or impulses. It is with these impulses that every thought is put into an action, whether it is a thought process, a cognition, behavior, as well as all our functionality, which may be special senses in terms of a vision, as well as your movements, your sensations, your balance, and sphincter control. Everything is a process which is a thought, and that energy is then transmitted to action by these signals, and that is transmitted through these coverings called myelin, and that is destroyed by this autoimmune process. Simplistically put in, that is where it is. But however, it's much more complex than that. And we know that it can cause a lot of stuff other than that in terms of shrinkage of parts of the brain or the whole brain. And the person as such can get disabled in various severities. And these attacks happen. So every time there is when we call as a relapse, it's an attack where there is this portion of the system wherein there is stripping of the myelin, and then it regenerates, it recupes, it may recover, but then it happens again. So whenever these attacks happen, spread over a period of space and spread over a period of time. In the space means it can happen in an eye, it can happen in your balance organ, it can happen in the spinal cord, which is controlling your movements, the stiffness or the tone of the body or sphincter control. So when it happens in different regions of the brain and spreads differently over a period of 6 months, 1 year, couple of years, it keeps happening. So that is what is called as a relapsing and remitting course, which is classical of a classic multiple sclerosis. So the symptoms, I'm sure all of you, at least those who know MS, who are living with MS, or caregivers of MS patients would understand that the common complaints are all these. They could be sudden, relatively acute. It doesn't happen over a period of minutes. It happens over a period of days or a couple of weeks that you have a movement issue. You may have an imbalance. The imbalance in movement issue is in terms of locomotion or in walking, in terms of tremors, in terms of spasms, in terms of tightness, and obviously speech issues. You can't understand, you don't produce the right words, you don't produce the right pronunciation. So it both articulation as well as language, in swallowing, in breathing, in vision, which is one of the commonest complaints that can be there, severe dizziness, pins and needle sensation, pain, heat, and sensitivity, regulating the body temperature will become really bad. Sphincter control, urgency, which is horrible. It is, it's one of the most disabling features that you can have when you're living as a society person. Your movements are so damn curtailed because of the sphincter control issue. And then there are these other things which you don't even talk about, the silent features, and you don't even want to attribute it to a particular illness because there is a fog. There's a confusion. You're not the same person anymore. The personality changes, memory disturbances, the executive functions. What was so easy to do as a multitasking now becomes a Herculean task to do so. And then you have the fatigue. How many people know about MS fatigue? About 80% of MS people have this really bad fatigue. The fatigue, you can't describe it in words. It's just that you don't want to get out of the bed. And once you do, everyday chores become, humongous effort to do so. That kind of a fatigue. So concentrating on work and getting through the usual learning abilities when you are a student, all of them come into this conglomeration of a compendium of signs and symptoms which can define and which can be part and parcel of a multiple sclerosis. Now, why do we get this? Really, no one knows. There are a lot of factors which have been implicated. Somebody is genetically predisposed, and that is true. When you have monozygotic twins, when you have two maternal twins, the one twin having it, the other twin getting it is very high. Less so in paternal twins. And when you have a sibling, yes, there is a risk. When there is a parent and a sibling, the risk is high. But generally, when you don't have it, the risk is the same as anybody else in the population. So you don't attribute it only to genes. But when it happens, it is there and the risk is definitely there. We don't know really the triggers. Very recently, we found Epstein-Barr virus, which has come up in news. We know the COVID era and the vaccines and the COVID infection and a whole lot of history beyond, which went in. There were actually fables which were spun around the whole thing. But the solid science, is also, I think we should wait for that to gain the weightage to be able to say that, yes, this is it and this has caused it. But we know whatever it may be, something which is predisposing from within, from outside, something is triggering, which may be temperature, it's where you're born, the equator above or below, irrespective of whatever it is. Finally, it is an immune attack and what we had talked about. Then they say that this low vitamin D, this is for something which I can really never fathom. I've even asked Dr. Rohit about this, that in India we have plenty of sunshine. It is not that we are bereft of sunshine, but for some reason we are all low vitamin D. Maybe there's an absorption issue, but it is generally been seen the vitamin D, being low, and there is evidence to say that definitely at least you need to give this vitamin D supplements to people living with MS. And then you have, I guess, apart from Epstein-Barr virus and the fact that as you move away from the equator, the number of people with MS increases in the world population. Other than that, and then you have the gender. Yes, there are a couple of things in nervous system disorders where women are predominantly affected. One is, of course, is autoimmune things, all autoimmune, including rheumatoid. You have multiple sclerosis as well. And the other thing is migraine and all sorts of funny headaches, isn't it? So in any case, that is there. We have a gender predilection. We have a little bit of a genetic predilection. We have a little bit of the geographical predilection. But then nobody says yes to smoking. So that is there. But in any case, we still do not know why this happens. And that's the reason, you have these big complex cartoons up here. That you have the brain, and then you have this nice big, the neuron with all its complexities, and the numerous places where things go wrong. And ultimately, you have this demyelination. The numerous places where things going wrong are also important because these are the places where they're developing drugs to be able to counter the disease. That's the beauty of it. Because if you understand at least why and how the disease process starts and progresses, and those little caveats wherein those gates or portals where you can intervene, you can make a difference. And no wonder, therefore, before 1993, there was no drug for multiple sclerosis. And in 1993, the first drug which came into market was an interferon. That was a beta interferon. And now when I put up a slide for my students, the slide is full. You have more than 17 approved drugs which are there for multiple sclerosis for every stage. Whether you're coming in day 0 of the illness being diagnosed and very early stage, to a level 4, where things are all, burnt out and you come very late and there's a disability, there are drugs available. Albeit most of these drugs are very expensive. Now there is hope. There are few drugs which are generic, and a lot of drugs are available in India. And beyond the drugs, there is a mechanism which can be put in force, which can tackle the other complications which may happen and the disability as it stands. So the most important thing there is to get the right drug to the right person at the right time. If it's not done, also don't give up hope. There is, hope dwells eternally in human mind, but I think hope is the one which will also drive us forward to be able to get the answers. So the mechanism of action, MOA is a mechanism of action. There are a lot of drugs which are actually targeting each and every portal. And so all these drugs, and most of you would know fingolimod, teriflunomide, rituximab, ocrelizumab, interferons, natalizumab, and these are the drugs you're familiar with, and there are at least a dozen more like this, including stem cells. Okay, so we need to treat early, and that's again a no-brainer, because now this is like a tip of the iceberg. So here are all the red lines which are not visible. So when actually the first visibility of a problem starts off appearing, see, this is the threshold, okay? Things are happening. So maybe the first attack of an optic neuritis, one eye, the vision has gone, and you give steroids and the vision has come back. You're happy. But that's not the end of the story, because by now there's a whole lot which has happened already underneath. And you don't do anything to it. You just give steroids and then you wait for another attack to happen, knowing that an attack may never happen. Then this is the disability, ladies and gentlemen, which will keep progressing. And by the time there are 2-3 attacks, look at the disability. You're already into a progressive illness. You may not even get attacks, but still progress in your rigidity, in your stiffness, in your walking ability, in sphincter control, and in cognition and other mental capacities. So there's an unseen activity which is going down. So the moment you get a diagnosis, you have to be on drugs. So therefore, treating early is a no-brainer. It's not a rocket science to understand this. You must treat early. And that is what is said, that when we actually calculate the EDSS, which is a disability score, when you come to our MS clinic, we always write there EDSS is this number. And we want to keep it 0, because the moment it happens to be around 3, this is the way the disability. So disability is, supposing it takes years to come to this phase. Slowly, there's a problem in walking. But the moment the EDSS is 3, it just shoots up. And this is the magic figure 6, where you're coming down to a wheelchair. You need so much of support, and 7 and above, you're wheelchair bound. You don't want that. Not at an age when you're 20, 25, and 30. You don't want this disability to happen. And the other thing we never mention is cognition, your mental capacity, your aptitudeness, your attitude, and the memory and the executive functions, and the you that defines you. That's not going to be there. It's not just physical. It's your mental capacity. And that's not even, always measured. And there are people who are, sometimes you feel they are very jovial. They're abrupt. Their control over emotions is fragile. Those personality changes are very subtle, and they're difficult to deal with. And the close family, the spouse, the children, your parents will be able to discern that. And when you are an employee, the employer will know it. So there are ramifications of this that goes beyond simple definitions of a disability in terms of motor or sensory or sphincter. And this is well known in MS that this can happen. So therefore, again, it underlies the importance of treating early. And so there is definitely 100%, chances of being better and to live normally with MS if you are able to get into this window of opportunity of early diagnosis and early treatment. Okay, otherwise you're just going down the hill. So the benefits of the disease modifying agents are a whole lot of them: to lower the rate of relapses, number of relapses. Even if it is there, it hopefully it becomes much milder than being very severe, and as well as no disability, and then quality of life should improve. And then you have a very important biomarker, which is MRI, which will tell you the number of spots and how many are enhancing and what is happening to the atrophy, and there are a lot of parameters in it. And then we have what is called as NADA, the no evidence of disease activity. That's the goal that we have. There are several other terms which have come, which are gaining in popularity over NADA. But then we are not going to talk about it. But just remember that a lot of people come and ask, how long do I have to be on this medication? And then we say that, yes, reach NADA, and there are levels of NADA. It is just not relapses or disability or your MRI activity. When you attain a NADA of significant, the level and the number of years on NADA, at least couple of years, then at least we de-escalate the disease modifying therapy. And sometimes whenever there is pregnancy on the offing, do I need to get into, can I now plan a pregnancy? You probably can be off drugs. So those have to be individualized, and we do that. So that's a pyramid that we always look at as to MS is not uniform. किसी को one attack of optic neuritis and they are well for 2-3 years later another optic neuritis, but there are some who get optic neuritis, 1 महीने के बाद they get a brainstem dysfunction, so they are they have an imbalance, they are seeing two images, and there is speech problem, their inability to walk. Another couple of months later, then they come down to completely a wheelchair. There's this highly active variety of MS. So the spectrum of multiple sclerosis is also defined when they first come to us. We have a way of determining what kind of an MS, and then we determine what kind of a treatment. So it's never one glove fit all approach. It's never there. So the treatment options, you have oral drugs, you have injectables. As I said before, there are several levels of managing, but we also determine which patient will get which level of treatment from day 0. If it is highly active, I may not go to level 1, I may go directly to level 2. So that is called induction therapy. So I hit it hard when there is a need, bring it down to a manageable level, and then continue on level 1. So there are various ways to deal with it. So one size fit all will never approach, will never work. So it is a shared decision making. There are sometimes, that's the reason, I know Dr. Rohit sits across with his MS patient and he's there for about half an hour discussing the possibilities, because you need to tell this to an educated young individual with all the complexities of life going on in that individual. So you were to discuss whether can you take an injection? Do you prefer an oral drug? How pocket friendly that it is. All these drugs are not free. Unfortunately, we've not come to universal insurance where I can just choose a drug and forget about finances. So I also keep that very consciously in mind. So, you can't say that to a person who can't afford and say, look, this is the drug and this is horrendously expensive. If you give that, you will be okay. That guy will be broken. So we need to take a lot of cognizance into a lot of aspects at a patient level. So all this is science, ladies and gentlemen. For a patient, individually, that patient is unique to us, and that's how we approach. So it is a shared decision making. And as I said, there are pyramids wherein we escalate step by step. Level 1, not working, to level 2, not working, level 3. Sometimes we just invert the pyramid. Very highly active, I start with the level 3. And then as I get stabilized, I go on to the level 1 drug and maintain on a low dose drug. So there are a lot of strategies that we do it. So, and then the diet, is there a best diet? I think that the Google is full of, very colorful, compositions of how you must live your life. But in general, I think it is universally applicable to eat right and, be physically active and do the right thing, not smoke, not, drink alcohol. By the way, I must tell you, even a drop of alcohol is bad for our brains, okay? And that is told by the World Health Organization. So no amount of telling me it is red and Vibgyor colored wine doesn't help me. So no alcohol there. So no smoking, no alcohol, be physically active, eat right is something which will make you healthy anyway, mind and body. Whether it is preventing you from stroke and preventing you from infections, from COVID, from, diabetes and control of hypertension, also MS. So the best diet, is there a best diet? No, I think the diet has to be geographically, contextually suitable to you. So don't go and, spend half your salary on getting olives or, the olive oil. No, you can be contextually right in your own setting. And yes, in general, whatever is told as a good diet is applicable even for MS. So is it ever too late to start a course of management in MS? No. So there are a lot of misconceptions related to MS, that you can't lead a normal life. This is completely wrong. Okay? That's the reason I said when you get the right drug to the right person at the right time, it's just normal. And Will it always lead to disability? Definitely not. Will everybody end up in wheelchair? Absolutely not. It is just a certain percentage, some unfortunate, some unfortunately because of lack of awareness, and that's the reason we are all here now. And also because of sometimes there's a barrage of, the what you call advice, which is given by people who have knowledge kind of thing, and you get confused. And there is this intrinsic belief that anything to do with allopathy is bad. So don't go by that. The holistic health needs an amalgamation of all health delivery systems. Whether it is yoga, it's meditation, it's allopathy, it's Ayurveda, whatever, all systems actually give you the right advice. An amalgamation of all systems is important for the right cause. If there is a road traffic accident, somebody is bleeding to death, will you sit and do meditation? No, isn't it? Will you go and take homeopathy? Will you go and take Ayurvedic preparations? Or will you rush the patient to a hospital to get an emergency surgery to stop the bleeding? Every system has its place in providing you the holistic health. So believe me that you need to get the right advice. If some mom has an MS, will the kid get it? Not necessarily. We talked about it. The chances are more that the kid will not get it. Is it safe to get pregnant? Absolutely. In fact, pregnancy is the least, in fact, I must say the safest period of MS that you have, logically, because it's an immune tolerant situation. So yes, you definitely need monitoring. There would be caveats. It's an umbrella. So under the umbrella, the large part of it is absolutely safe. And therapy is not needed for milder cases is absolutely wrong. As I told you before, the first attack, however mild, it's just gone beyond the tip of iceberg. There is a whole lot below already ongoing. You will need it. Is there a way to slow the MS from progressing? Absolutely, yes. In fact, there's a lot of advances now happening in terms of disability progression, reduction. So get the right drug to the right patient at the right time. So thank you all. And now, I'll hand over the mic to Dr. Rohit. Thank you.
So good evening, everyone, and thank you again for coming. I know everyone is busy, but it's a time that we all want to interact with you in person, so that gives us an opportunity to understand issues as well as share experiences and knowledge with you all. So I think with this brief introduction that Dr. Padma gave as an overview to kickstart the discussion, we will now open the discussion for all of you present here to put up questions. Our request is generally that the questions should be more general, even though that could be related to your experience, but it should not be very focused specifically like a consult question, but it should be a more general question, because it will be difficult for us to answer a very direct consult question since we will not know the details of the case more in depth. So we welcome you to please, there is a mic there in the center, and we'll also arrange for a hand mic. So you can please start and ask questions which you think are relevant, pertinent, and our team here would like to interact with you all. So please start. Feel free to please question, no problem.
Namaskar. I'm of 84 years age. The attack came to me about 1 month back. Suddenly I start falling towards left side, not right side, but left side. And people tried to hold it, but it could not. I fall this way, this way, this way. Is it it comes under this category or not, please?
Sir, it's very unlikely that we are dealing with a disease like MS, because MS generally is a disease of younger population, and we normally give a cutoff of anything close to 50 to 60. I mean, 60 is also the upper limit. Most of the patients who present with these disorders generally present in a mean age, anything between, an age range between adolescence to late adulthood. So we see mean age of about 30, but it could be at a adolescent age group or 35, 40, 45. I think your symptoms, which if they are abrupt and at that age, if they were abrupt, then you need to seriously consult a physician or a neurologist to assess why it happened. Is it a stroke-like symptom? Is it something to do with cardiac, or is it something that needs a more detailed history taking? So, but feel assured that this is not MS happening to you.
What is the present research going on this subject?
Sir, multiple things are going on as a research project in multiple sclerosis, from models to understand the pathophysiology of the disease to newer treatments that are coming in. We did not have any treatment for MS up to the early 1990s, and now we've got more than 15 drugs that are available for treatment. Initially, we only had injectables. Now we've got oral tablets that are available. There are multiple more drugs that are in the pipeline which are being tested. So, and we're also looking at other symptoms of MS which are not usually looked at. Like people tended to look at MS only from an episode wise. Like somebody has had vision loss, so that was treated. Somebody has weakness, that was treated. Now people are looking at whether in the absence of an attack, is there some degeneration that goes on? Do people have cognitive impairment apart from all of these things? So multiple trials are ongoing, multiple studies are ongoing, not only to understand the pathophysiology of the disease, but also from the treatment point of view. We should have answers in the coming years.
Hi Rohit sir, my name is Nidhi Chadha Gupta. I was having your treatment up till I was Nidhi Chadha under my parents' guidance, and I had very wayward symptoms like inability to walk properly, having pins and needles on the right side of my body.
Can you just be a bit louder?
Okay. I was having wayward symptoms like tingling sensation on the right side of my body. Such were my symptoms. You had suggested Evonex, but I was very scared because I was in the prime of my life. I was very scared. Took about 1 month, 2 months of Evonex and then discontinued. And then post that, I got married in 2017. Since 2018, my right hand has a permanent tingling sensation. I've had, steroids, but nothing has helped. But Renu Atani ma'am suggested MS-240. So since after the baby, I could go for an MRI. I saw a lot of lesions and everything in my brain. Apart from the tingling in the right side of my body, I'm not able to walk properly. So, and my thinking, although I'm working a job, but my thinking is not as great. My position is great in EY, but my thinking abilities and the way I speak is not the same. So I'm having MS-240 under Renu ma'am's guidance because I didn't want, I used to panic from injections, is my story. But now I'm having MS-240 night and day, in the morning and in the night. So is that correct? Is that the way to go about it?
निधि वापस आया करो डॉक्टर के पास. So the point here is, which I always want to make to all the, all parents, patients sitting here, is that coming back to your doctor and following up with the doctor who knows your natural history from inception is the most important thing. Yes, if you feel at some point that the consultation is not treading on a path that you expect it to be, or you want a second opinion, that's always good, because a different mind may think differently. And we all are colleagues across the country, and we discuss amongst ourselves also when we have some difficulty in making a decision. But Nidhi, in your case, these evolving and worsening symptoms, you need to seriously come and get yourself evaluated. Because we need to decide the drug that you're taking is the right drug for you or not. Because if you're getting these progressive worsening features that your ambulation is going and you feel cognitively, I know you're a bright person, you're working for Ernst & Young. I remember everything about you. So you need to come back because you may need a much more effective drug than what you're on right now. So that decision is something we like to take after a detailed evaluation of you.
Come on Tuesday.
Next Tuesday it is. Thank you.
नमस्कार जी, ये डिजीज मॉडिफाइंग ट्रीटमेंट है सर, जो इसको मतलब कि ये क्योर तो नहीं कर रहा ना, डिजीज को मॉडिफाई कर रहा, ठीक है, और इसका दूसरा मतलब कंट्रोल के लिए स्टेरॉइड का किया जाता है। तो ये जो डिजीज मॉडिफाई है तो एक तरफ वही बात हो गई कि एक तरफ कुआं एक तरफ खाई।
तो मैं आपसे एक क्वेश्चन पूछना चाहती हूँ सर, आपके नज़र में इन्फेक्शन के अलावा, इन्फेक्शन को छोड़ दीजिए, इन्फेक्शन तो बैक्टीरिया, वायरस है, फंगस है, जो भी है, इन्फेक्शन के अलावा और कौन सी बीमारी है जिस्म में जो क्योर हो जाता है? एक डिसीज मुझे बताइए आप।
मुझे भी नहीं है।
नहीं आप बताइए, आपको तो याद होगा। जैसे आप कोई भी डिसीज आप लीजिएगा, ब्लड प्रेशर का बीमारी, डायबिटीज की बीमारी, हार्ट का है, कुछ भी है, इन्फेक्शन के अलावा बाकी डिसीजेस कंट्रोल होता है। जो कंट्रोल के मतलब है दैट दे आर ऑन सम मॉडिफिकेशन, आइदर दवाई या लाइफस्टाइल या वॉट एवर, आप खान पान, फिजिकल एक्टिविटी, वॉट एवर इट इज, जो आपको अपनाना पड़ता है ताकि वो कंट्रोल रखे। तो एमएस भी ऐसे ही कंट्रोल्ड होती है जैसे आपकी मिर्गी की प्रॉब्लम्स होता है। यू कंट्रोल द डिसीज बाय अ सर्टेन अमाउंट ऑफ मेडिकेशन। वैसे ही जैसे एपिलेप्सी का कुछ कोर्स है, आपको 3 साल कोई बीमारी नहीं आया, वी ट्राई एंड रिड्यूस द ड्रग्स। इसी तरह मल्टीपल स्क्लेरोसिस ऑल्सो, वो नेडा की एक्टिविटी में अभी हमको दवाई को कम करना, समटाइम्स गेटिंग ऑफ इज पॉसिबल। डू यू हैव अ क्योर ऑफ अ डिसीज? यू शुड डिफाइन कि व्हाट इज मेंट बाय क्योर, दैट इज इंपॉर्टेंट। सो देयरफॉर ये जो हमारी जो जो व्हाट यू कॉल योर थिंकिंग इज, इसका तो देयर इज नो क्योर एंड देयर समबडी हु सेज कि इसका तो मैं तो क्यूर ही कर दूंगा। ये लोग तो कंट्रोल करते हैं, स्टेरॉइड देते हैं, तो मैं तो क्यूर ही कर दूंगा। इसी चक्कर में हमको सैकड़े ऐसे यंग लोग आ गए हैं जो डिसेबल्ड हो गया, जो व्हील चेयर पे आए हैं। इनफैक्ट आई डोंट इवन वांट इन टू गेट इन टू द डिटेल्स ऑफ दैट, it's so much tragic to see these young people completely disabled because of this very process। कि कोई आके कह देता है कि ये तो मॉडिफाई कर रहे हैं, ये कहाँ से क्योर कर रहे हैं, ये तो वहाँ तो वो लोग तो क्योर कर देते हैं, वहाँ चले जाइए आप। एंड साइंस इवॉल्व्स एवरी डे, देयर इज अ रिसर्च एंड अ साइंस एक्टिविटी। आप हमारे जनरेशन में, जो पहले जनरेशन था नहीं, आगे के पता नहीं होता है नहीं, वी हैव सीन कोविड पैंडेमिक जो 100 years में जनरेशन्स में नहीं था। कोविड के जब पैंडेमिक आया था, हाउ डिड वी इवॉल्व? वो साइंस से ही तो टीच किया था ना, पहले तो कुछ पता ही नहीं था इस डिसीज में, कितना भय थे। अब आ गया इस साल में जो कोविड आया, कोविड गया, कोविड है, वी आर नॉट बॉदर्ड बिकॉज वी हैव इवॉल्व्ड, वी अंडरस्टूड। बट वो अंडरस्टैंडिंग कैसी आई? विद साइंस। तो इस डिसीज में भी साइंस इज ग्रोइंग एंड वी नीड टू ग्रो विद इट। So please understand that diseases are mostly controlled. There may be a chance for a cure. When the science comes, you will get a cure. But before you reach that, if you think इसमें cure नहीं है, therefore why should I control it? That is wrong thinking.
नहीं, वो ठीक है मैम, ये मेरे को लगता है कि ये इसलिए माइंड में आती है बात कि DMT MS के साथ ओपनली कहा जाता है अदर ट्रीटमेंट में डिजीज के लिए नहीं बोला जाता है ऐसा, शायद इसलिए इमेज बनती है।
सर वो अंग्रेजी का टर्म है, ऐसे ही बना है तो वो चल रहा है, बट
मतलब
डिजीज
दूसरी डिजीज के लिए नहीं ये यूज होता, इसलिए।
उससे कोई फर्क नहीं पड़ता है सर।
अच्छा,
डिजीज मॉडिफिकेशन का मतलब है कि कुछ पेशेंट्स के लिए तो डिजीज बिल्कुल साइलेंस ही हो जाती है, मॉडिफाई हो जाता है।
In anyhow, I don't think you should think too much about it. Disease है तो प्लीज आप ट्रीटमेंट
तो
लीजिए.
मतलब कि इसको जो है स्टेरॉइड से प्रेफर करना चाहिए डीएम।
नो, स्टेरॉइड इज फॉर एन अटैक. जैसे आपका कोई इन्फेक्शन है तो जैसे आप एंटीबायोटिक देते कि वो कर दे, देन इम्यूनिटी बढ़ाने के लिए बाकी आती है. दिस डिसीज व्हेन देयर इज एन अटैक यू गिव स्टेरॉइड टू कंट्रोल द अटैक.
अच्छा मैम, एक क्वेश्चन
सर आपका होने, देयर आर लॉट ऑफ पीपल बिहाइंड यू, तो आपका आ जाइए, वापस आ जाइएगा. उनको आपके पीछे 6 लोग खड़े हैं.
Hello, my name is Prashant. I was diagnosed 7 years ago, and after initial treatment with steroids for attack of optic neuritis type of symptoms, I've been taking a drug called Plegridy from my neurologist for the last 7 years. And, I've not had any worsening on MRI. Like every year, the MRI shows that there's no disease activity, there are no new lesions or anything like that. But definitely there are still cognitive problems, and there are mood problems, and I'm wondering if Plegridy is the right drug for me to continue.
Sir, it is difficult to give consultation regarding individual patients, but some patients might have certain cognitive issues with certain drugs. In your particular case, what exactly is the underlying problem that needs, I think, personalized evaluation and treatment? I would suggest you to attend the clinics in our OPDs.
Okay, thank you.
Come for evaluation, we can look into these things.
Okay.
Okay.
All right, thanks.
Hello, doctors on the panel. Actually, before coming here, I had no idea much about this multiple sclerosis. I do keep attending lectures. I knew only about multiple myeloma. I am multiple myeloma survivor for last more than 2.5 years. Now, for last couple of days, I'm having some loss of sensation in my fingers of my foot and little bit in the fingers of my hand. So just listening to your lecture, so I thought, do I have multiple sclerosis?
No, it's not, sir. But however, in myeloma, once when you develop these features, एक बार आप consult कर लीजिएगा. There are sometimes there's involvement of some nervous system issues in that. It's not MS, it's not multiple sclerosis, but it's better that you once, get a consultation from your, the primary doctor once.
The primary doctor say, my doctor, the doctor, he talked to that doctor. He said, no, it is not because of that.
No, whatever, we need to know why it's happened. So sometimes they do refer for certain conduction studies and all to neurology. इसीलिए मैं कह रही
It is
थी.
not MS.
It's not MS.
Thank you. Thank you.
Hello, Doc. I had a question regarding the current treatments. The treatments which, can you hear me? Yeah. Sure. So I wanted to understand the current treatments which AIIMS Delhi is using. Among those particular treatments, which treatments have shown effective results for SPMS versus RRMS? Because SPMS is already progressed. So I wanted to understand, have those particular drugs actually impacted SPMS patients too?
Yeah, thank you for the question. So at AIIMS, we have all the drugs that are available in India for MS to be offered to patients. In terms of RRMS or drugs for SPMS, we have all the armamentarium. Professor Padma has already mentioned a lot of those drugs. So all of those are available. And based on the patient's disease activity and other things, so one can decide individually as to which would be the drug of choice for an individual patient.
Yeah, so my question...
I'll add out to what Devyani said is that there's one thing that you must remember, that SPMS itself is not an entity to start with. SPMS is a transition point from someone who's had RRMS features but looks declining without evidence of relapses, clinical relapses, or sometimes you may have interspersed relapses or MRI disease activity, which we call active SPMS. Now, in secondary progressive MS, the aim is twofold. One is that you want to control disease activity, which may not be there apparently, and to stop the disease progression. And I always say that in forums when we discuss that, there is always that transition period which a patient must realize and the doctor must realize when he's following up a patient, because that time point from transition sometimes is good point where you can actually transition someone to a more effective drug. So in SPMS, if you talk about approved agents, we used to use a drug many years ago called mitoxantrone, which was basically a cancer drug, but later started to be used in 1 and 3 months injection, and slowly, because the drug's use was not that much, because SPMS patients are much lesser than RRMS patients, the manufacturing of the drug just went out of use, and we used it in a lot of patients previously, but now that drug is not used because of its cardiac adverse effects, long-term hematological adverse effects, so kind of fell out of use. In the meantime, internationally, siponimod got approved, which is an oral drug. The same generic drug called fingolimod, its previous congener, is available in India as a generic, but siponimod is one which got approved for MS, which is not available in India as of today. The other agent which was approved, which is also being used, is called cladribine, which is a drug which is also given for a fixed period of time. It's a drug which is used for a blood cancer called hairy cell leukemia. But the oral formulation of cladribine is not available. The injectable one is used by the oncology people, but the oral is not available. The third drug which people use sometimes when they see people transitioning, although that's not really approved typically, is the ocrelizumab, which is the drug for primary progressive MS. Now, saying so, we have a drug in India called rituximab, which is a same molecule in the same pathway of ocrelizumab, which was tried for primary, RRMS has been tried a bit for secondary progressive MS. Now, if you look at the approved indications, you won't find it in the FDA approved list because it is not really an FDA approved drug for MS. But as an off-label treatment, internationally and nationally, this is used a lot because experience has said that it may work similarly to other molecules by clinical experience gathered over a period of time by a lot of experts internationally, and a lot of papers are there about rituximab as well. So choosing a right drug for the right patient depends on availability, also on the cost, and also on the adverse effects of the drug. So we can go by the stringent, what we call semantics, that okay, this is SPMS, this is my list, and I don't want to move around it. ऐसा नहीं होता है practice में. We have to think a lot to move around and make sometimes decisions which could be off-label as well, but suitable for a patient's profile and for the disease time point cross-sectionally. So I think that's what we do in typically around, and we move around and then make a choice as to what seems to be the best option. Now, there could be some time no drug and patient may be transitioning very fast, not showing benefit to even good drugs, where you may have to even consider a autologous bone marrow transplant. And that may also halt SPMS, because it is not that it has never been used for SPMS, but it has definitely more closer to approval for RRMS. So I think this is a decision-making, individualized decision-making, which we may have to take.
Thank you, sir.
Yeah.
That explains.
Hello, thank you so much, sir, for organizing this beautiful event. I actually just want to ask one general question, as you suggested. So, there are some researches that that shows the relevancy of heavy metals or metal toxemia that triggers oxidative stress and ultimately making T cells to inflate blood-brain barrier and target myelin sheath. So in case, yes, if this patient is having metal toxicity, can we diagnose it? And is it possible to remove heavy metals through any treatment, sir? This is only I just want to ask.
It's talking about heavy metals. It's a good question. And I think in the research realms, there probably had been some trials on that though. At this point, though, we do not have the evidence or the level of science backing us up where we would test for heavy metal intoxication in people coming with multiple sclerosis to us. There may be situations where we would suspect some kind of exposure to heavy metal toxicity, which we will not categorize them as multiple sclerosis. There would be some syndromes that way where we would do test for them in terms of heavy metals. But currently, is the exposure to heavy metal sine qua non to development of multiple sclerosis? No. So therefore, the management of trying to take out a heavy metal in these patients also doesn't come into. At this point, no.
So, yeah.
सभी को नमस्कार, मेरा नाम नवीन कुमार रोहिला है। 2015 में मेरे को RRSMS में हुआ था। 2019 तक मैंने एवोनेक्स लिया। अभी मेरे पास कोई मेडिसिन नहीं है। अभी मेरे को केवल ये प्रॉब्लम होता है कि रात को नींद नहीं आता है, रेस्टलेस जो होता है ना वो मेरे को होता है, और नींद का गोली के बाद भी मैं 2-3 घंटे से ज़्यादा नहीं सो पाता हूँ। क्या ये MS के कारण है मेरे?
देखिए, आपका MS स्टेबल हो गया है 4 साल के ट्रीटमेंट के बाद, ये एक अच्छी बात है। लेकिन अभी जो आपको नींद की परेशानी है, ये MS के मरीजों में हो सकती है। कई लोग को नींद नहीं आती है, कई लोग को बहुत ज़्यादा नींद आती है। तो अगर आपको ये है तो एक बार आपको कंसल्ट करना चाहिए अपने फिजिशियन को, जिसको भी आप MS के लिए दिखा रहे थे। वो कुछ जांच करके देख लेंगे। अगर अभी भी यही रियलाइज़ होता है कि आपका MS स्टेबल है तो अच्छी बात है। अगर आपको कोई दवा दे दी जाएगी उससे आपको नींद आ जाएगी। लेकिन अगर आपका MS अभी एक्टिव है तो उसका इलाज चाहिए होगा, उससे बाकी सारी परेशानियां भी ठीक हो जाएंगी।
सर नींद की गोली भी दिया है, उसके बाद भी
नहीं तो, लेकिन केवल नींद का गोली लेना सही नहीं है, क्योंकि आप MS का ट्रीटमेंट पिछले 4 साल से नहीं ले रहे हैं। तो अगर आपकी MS अभी एक्टिव होगी तो उसके ट्रीटमेंट की भी ज़रूरत होगी, क्योंकि ये उसका भी एक सिम्टम हो सकता है।
थैंक यू सर।
Good evening. I just wanted to ask, sir, I was on Avonex for 13 years, then I shifted to Tecfedra 3 years ago. And after my 5th COVID infection, I got COVID, then my walking ability completely deteriorated. Like it was just 1100 steps. I could walk 17,000 steps. I could just walk. So when I went to a doctor, he said, you transitioned immediately into secondary progressive, and I've never left my medicines ever. So what? How could it progress within like a month or 10 days into secondary progressive? And I'm also on Dala step twice a day, and still it is not that effective for me.
So, it is possible that certain infections, especially after COVID, certain patients have experienced a rapid deterioration. But it is better that you get yourself evaluated if it is...
The lesion load has been the same. It has not increased. It's the same. My lesion load has not increased in the progression.
So
how does the patient come to know that I'm going to go into secondary progressive when the patient has not left his medicines and still the progression is continuing? What can the patient do?
So it is possible that one thing is that certain complications have happened, like development of tightness in the muscles. Patients who have long-standing multiple sclerosis can develop spasticity, and worsening spasticity can occur. The second is that it is possible that you have transitioned into a secondary progressive MS. The third is sometimes...
How can you protect yourself, like you taking the medicines?
Yeah, I'll take it. So there is a term now called PIRS. So it is progression independent of relapses and activity. So again, I told you that the science is evolving. So these are the terms which are now coming into, and the knowledge is growing that you may not have clinical relapses and attacks. You may not even have the number of lesions on an MRI changing, and still there is a disability progression.
Is there any drug which
So in this, we can try, see, dalfampridine is Dalstep that you're taking. This has been increased in its dosage also. Some people, I'm not taking, everybody has to go on to increase dosage. Apart from that, the disability part of it is also being targeted. There are some drugs which are coming in. So I don't know where, are you showing Rohit or me, or where I don't know where you're
Rohit sir for 10 years?
Okay. So we can actually look into whether we can start you on some of the other medications. So, but this is now a known entity, and these, as I told you, this is a new term which has come now, where there is no evidence, but there's a progression. Yes.
The progression can be
Yes. Yeah.
Thank you.
Abha, come to the clinic.
Yes.
Yeah, we'll look at that.
Thank you.
Coming is the game. Come.
Thank you.
I have this question. How do a person cope up with the side effects of the drug they're taking? Like side effects like fatigue, numbness, headaches, or nauseous feeling. So how do we cope up with these side effects?
Yeah, thank you for the question. So MS drugs can be associated with the side effects that you've mentioned. It may be part of the drug side effects, but it can also be part of the disease per se. In terms of managing side effects of drugs, there are many things that we can do. So, for example, maintaining a healthy lifestyle, as Professor Padma had said, taking care of your diet, taking the pills on time, all of those things are important. But if the symptoms are a little more significant and they are affecting your daily routine, then there can be certain drugs to counter those side effects. So, for example, if you're having a lot of acidity, then one can take antacids. And if you're having a lot of fatigue, there are also medications for that. A lot of patients with MS can also experience a lot of body pain. So that can be another problem. So we always suggest that it should be a multidisciplinary kind of approach towards treatment, that you show not just your physician, but you also take care of your diet, your lifestyle, and also good exercises, the physiotherapist. All of those will actually take care of a lot of these smaller problems.
Maybe we can add, Dr. Pinto, would you want to add on to that?
I will add in this, you have to do some certain exercises to prevent the contracture or something like that. Then you have to do the stretching of the muscles. Also take a deep breathing exercises to prevent the lung complications. Also for the strengthening of the muscles. These are the things you have to do regularly to prevent the long-term disability. Some patient may have the bladder and bowel involvement, then the pelvic floor muscles strengthening exercises is also recommended in these conditions. Certain to prevent balancing or the balancing or like a gait abnormalities, then gait training or something may advise to the patient.
Okay. And are there chances that sudden altitude change may cause any problem in the condition?
Altitude won't, but then when you're talking about the side effects, so I know that they are, if you'll actually look at a fine print of every drug, you'll have side effects listed. All of them don't happen to all of you. So it is very individualistic, but when a side effect happens, then there's a way to deal with it. Like, for example, somebody has a transient rash with one of the drugs. Then there are certain modalities, usually these side effects are in the first 3 months and then they should subside normally. That's a normative, not necessarily. So sometimes we say, okay, you take a tablet of paracetamol with it and it may subside. Then there is also a way of taking the medication, you take it in between the meal. So, there are certain set of precautions. You don't do it, you may get some. But in spite of everything, you develop a lot of rash and there is stomach ache and you're not able to tolerate. Then we have to discontinue the drug. So you don't have to live with the side effect all the time. There is an array which you can choose from. But at the same time, the other things in terms of alternative systems, in terms of, doing some yoga, the breathing exercises, some kind of a physical activity and eating right will also help in sometimes tiding over these side effects. Okay.
Thank you.
Good evening to all the honorable panelists. I am Garvita. I was 19 when I was diagnosed with multiple sclerosis. Currently, I am taking Tecfedra, but I'm facing few, side effects or whatsoever they are, kind of fatigue, nausea, and tingling sensation, problem with excessive heat. Like what the temperature is outside, I'm not able to bear that temperature. And yeah, exercise intolerance. I was able to do exercise before my MS was diagnosed, but now I'm not able to do so. So is this common or do I need to change the medications?
I think in the first little bit of synopsis I gave about MS, I did tell you about all this, that all what you have described can be part of multiple sclerosis itself, especially the MS fatigue and heat intolerance. So it's a part of a disease. Then there are some times that you have some regimes to counter this that can be looked into. While you are on this is dimethyl fumarate, which you're taking as a disease modifying therapy. A lot of the DMF side effect profile doesn't have these things in it, like producing fatigue or heat intolerance. So we need to look at the disease as a whole. And what we want the DMT to do for us to not to have a clinical relapse and probably not to have increased activity on the MRI, though none of us here, we do MRIs frequently. MRIs we do pretty infrequently, but then that's one way of looking at the thing. So I think you're okay. Maybe beyond DMF, we need to find other things to be able to deal with fatigue. And you still look 19, by the way.
Let me add to this. In my second MRI, there was an increased lesion. So at that time, I was shifted to Tecfedra. So should I continue with this now?
So if the last MRI showed an increase in lesion load, you were shifted to another drug, that is absolutely fine. And on this drug, if you're doing fine, you're not experiencing new symptoms, then I think you're fine on Tecfedra. But if you experience a relapse on this drug, or if your treating physician gets an MRI done at whatever interval and it still shows that your lesion load is increasing, then it might be considered to switch you to another drug. But as of now, I think you're fine on Tecfedra.
Okay, thank you, sir.
Hello, doctors. So my mother was diagnosed with MS around 1.5 years back. Back then, she was suggested with scleroderma 240 twice a day. But even after taking those medications, still she had to take steroids twice from them to now. So now the doctor has shifted her medication from scleroderma to diaphragm 120. So, would you suggest anything?
So there is, what happens in the principle of treating MS is very clear as we have evolved in science in the last 3 decades, maybe 4. Is that you have to silence the disease early and not wait for it to deteriorate and make decisions. So like they say, in MS also, time is brain. Like we talk about stroke, time is brain. Only difference is in stroke, it's in minutes to seconds, but in MS, it is in weeks to months, maybe. So if your mom had been on scleroderma, which already contains a salt called dimethyl fumarate, and she's had 2 more relapses on dimethyl fumarate, there is no reason that she will be on the same salt. So what you're talking about diaphyra is in fact the same salt. Changing one trade to the other trade name is not going to alter her course. We would recommend that you please discuss it back with your neurologist so that you can actually interact and take a decision, or your mom and you both can take a decision about what should be the switch. Now, this is the time that we call switching therapy in MS. And there are only 2 decisions we have to take. Switch to the same effectiveness of the drug with a different salt completely. It's like someone not responding on fever to paracetamol, we may like to give the patient ibuprofen because that's a stronger painkiller and may have better effect on fever. Same way, but you can change from paracetamol to a different lighter drug also, but it may have a different mechanism of action. So it is called the platform switch. You choose between the same effectiveness but an exact completely different salt, or you go up, like Dr. Padma had showed you, to the next level of medications which are called highly effective treatments. So I think if your mother has had two or more relapses in the last 6 months or 8 months, and MRI shows higher disease activity, as a recommendation, we would recommend that she should be on a more effective treatment to silence the disease, if that is correct.
Okay, actually, I've heard that from many doctors that other medications have severe side effects. Or
एक तो many doctors वाला principle कम करिए पहले.
actually, उन्होंने
No, so I must also tell you that don't take too many opinions, that you homogenize them to what suits you the best.
Okay.
So what you need to understand is that side effect और ये सब एक हर एक disease का भी side effect है. Have you ever checked the side effects of paracetamol on net?
No.
So there are tons of them. But paracetamol नहीं खाते हो fever के लिए. So you have to understand that whenever a drug is chosen for a patient, all the adverse effects are explained. The patient profile is checked.
Yeah.
We also look into many other issues that could, further increase the risk of adverse effects than benefit. So when you make a good decision of benefit versus harm, and the benefit clearly outweighs the harm, you choose for the benefit. So don't get too confused. Please talk to your doctor. You're also more than welcome to visit us in our clinic to help you. So don't get too confused, but your mom definitely needs a change of treatment.
Sure. Thank you.
Good evening, doctors. My name is Nikhil. I was diagnosed MS in 2018. Actually, I'm living with steroids till then. I have done 2 MRIs have been done. The lesions have increased. I have switched to another doctor. Then also I have to take steroids for capsules and drips. So I want to consult I can.
आप आ जाइए. Next Tuesday आप आ जाइए. Okay. Just come. MS clinic है next Tuesday 6 तारीख को. Either room number 1 या room number 7 में neurology OPD में आ जाइए. You please come.
Thanks.
Okay?
Thanks,
Yeah.
Thanks.
थैंक्स मैम, मैं दोबारा आ गया हूँ और मैंने 2 क्वेश्चन को 1 क्वेश्चन कर दिया, आपको ज़्यादा परेशान ना करूँ. एक तो ये मैं पूछना चाह रहा था कि कोई ऐसा रिसर्च मेडिसिन की पॉसिबिलिटी है, क्योंकि एमएस में जो बात है एक तो ऑटोइम्यून की, दूसरे नर्व सिस्टम की, ठीक है, तो वो उस पर अटैक कर रहा है. तो ऐसा कुछ है मेडिसिन हो सकती है कि जैसे या तो इम्यून सिस्टम को कुछ उसका नेचर या उसका बिहेवियर चेंज किया जाए, या फिर नर्व्स के उस पर कुछ ऐसी मेडिसिन हो तो उस पर उसको कवरिंग करे या कुछ ऐसा हो.
एक्चुअली बहुत यस सर.
एक जो आपने वो ये है मेडिसिन
रिटुक्सिमैब,
तो ये मेडिक्लेम में क्या अप्रूव नहीं है, तो क्या मेडिक्लेम में पेएबल हो सकती है?
या सो द फर्स्ट क्वेश्चन जो आपने पूछा वो इट्स अ वेरी गुड क्वेश्चन. तो इसमें बहुत रिसर्च चालू है. व्हाट यू सेड इज वन इज कि वो जो माइलिन की जो ऑटोइम्यून अटैक ना ही हो, तो जो इम्यून टॉलरेंस बढ़ा दे, तो उसका लेवल ऑफ बहुत सारा रिसर्च आ गई है. दूसरी तरफ जो है माइलिन जो हट गई उसको दोबारा कवर कर दे, उसको रीमाइलिनेशन कहते हैं. उसका भी काफ़ी ऑलमोस्ट लेवल 3 तक वो जो आया. अगर वो ये ग्रेड और पास ऑन हो जाती तो मार्केट में आ जाता है मेडिसिन. तो ये दोनों तरफ चल रहा है. दूसरा जो आपका क्वेश्चन रिटुक्सिमैब जो है ये FDA अप्रूव्ड में नहीं है, बट इट इज़ अप्रूव्ड इन ऑल अदर इंडिकेशंस. जैसे इट्स एन अप्रूव्ड ड्रग. वो कंडीशन MS में अप्रूवल FDA में नहीं आया, हालांकि वहाँ के काफ़ी महत्वपूर्ण बड़ा ट्रायल्स हुआ है. तो इट इज़ बेसिकली इट इज़ अ पोर मैन्स ड्रग. It's not as expensive as other drugs. तो बहुत कुछ रिसर्च वगैरह बहुत बड़े बड़े कंट्रीज में होता नहीं, हमारे भारत देश के लिए बहुत अच्छी ड्रग है। तो हम लोग ने काफ़ी हद तक ये यूज़ कर रहे हैं, और इसकी जो एक्सपीरियंस है ये अभी पब्लिश हो गया इंडिया से कि ये बहुत अच्छी मेडिसिन है, तो वो एविडेंस भी अब आ गया है। तो यू कैन यूज़ रिटुक्सिमैब, एंड इसको इट शुड बी जो हमारे जो इंश्योरेंस वगैरह वो रिम्बर्स तो कर रहे हैं, जो सीजेच वगैरह वो सब रिम्बर्स कर रहे हैं अभी।
थैंक यू मैम, थैंक यू।
Thank you, madam. It's a matter of great honor to have your gracious presence here, stalwarts of people who are working on MS. मेरा बैकग्राउंड थोड़ा लीग से हटके है। आई एम डॉक्टर अखिलेश शर्मा, एन आयुर्वेदिक फिजिशियन। आपने आयुष काढ़ा जो सुना होगा, उसको मैंने कॉन्सेप्चुअलाइज किया था इस देश में। और मैं एक्चुअली रिसर्च साइंटिस्ट रहा आयुर्वेद में। लकीली मुझे यूएस में काफ़ी जगह काम करने का मौका मिला है, और वहाँ एक कॉलेज है, कैलिफोर्निया कॉलेज ऑफ आयुर्वेदा। सो वी स्टार्टेड टारगेटिंग सपोर्ट ग्रुप्स ऑफ एमएस इन यूएस, एंड वी गॉट, आई मीन व्हाट आई वांटेड टू से नटशेल, एक सजेशन था कि जो आयुर्वेदिक पर्सपेक्टिव से जो चीज़ें हम यूज़ कर रहे हैं, स्पेशली जब हैवी मेटल्स की भी बात आई, रादर आई वुड से वी आर यूजिंग सर्टेन हैवी मेटेलिक कंपाउंड्स एज स्ट्रॉन्ग इंडिकेशन इन सच केसेस. Some compound formulations like Ras Raj Ras. I'm opening the formulation also, which is coming from our proprietary medicines, which is a combination of some heavy metals like mercury, पारद जिसको बोलते हैं, and gold. हम मानते हैं कि रीमाइलिनेशन के लिए गोल्ड भी ट्रेसेस में रहता है माइलिन क्षेत्र के अंदर है, ये आयुर्वेदिक की जो पैथोफिजियोलॉजी की बुक्स में आता है. So that could be a revolutionary thought to have an integration and work together and incorporating some kind of panchakarma modalities like Shirodhara and rest of the symptomatic management of other complications of the medicines. That was my suggestion, madam.
Well taken, sir. What we welcome to anything which is backed by a sound science. So a sound science are in terms of randomized controlled trials, and a well-balanced RCT which demonstrate the efficacy of any intervention will be welcome to be, taken into a holistic healthcare delivery system. What we need is that science.
I appreciate that, madam. That's why what I'm saying is, in last 35 years of my clinical experience in this subject, I mean, we got really good results. I mean, when we can have a discussion at length, Padma, maybe I will meet you. Thank you.
गुड इवनिंग एवरीवन। मैम, जस्ट आई वांटेड टू नो कि जैसे आपने बताया कि बहुत सारी रिसर्च अभी इज़ गोइंग ऑन, तो अभी जैसे कोई यानी ड्रग है जो रीमाइलिनेशन में हेल्प कर पा रही है, या उसका कोई ऐसा कोई नाम आगे आया है क्या, विच एनी ड्रग्स विच हेल्प्स टू रीमाइलिनेशन?
अभी कुछ ट्रायल्स चल रही हैं, लेकिन FDA अप्रूव्ड ड्रग कुछ ऐसे अभी तक निकल कर नहीं आए हैं जो माइलिन जो चले गया उसको वापस लाए। ऐसे कोई ड्रग अभी तक अप्रूव्ड नहीं है, बट अनुसंधान स्टेज में बहुत सारे ड्रग्स अभी है।
तो वो अभी कुछ उसमें किसी को ट्रायल में जाना हो या किसी को ऐसा मिलना हो तो one can go for
Yeah, you can do that. You just have to get into a search, and all these major जो actually phase 3 trials में जा रहा है अभी।
तो मैडम कोई ऐसी कोई ऑर्गेनाइजेशन है, जैसे बहुत सारी मेडिसिन डेवलप जो ऑर्गेनाइजेशन होती हैं,
We have an MSSI society, we do have, but what I would advise you for a research part of it is that वो individual है, so you can get into that.
किसी कंपनी का नाम है जो जिन्होंने इस तरह की प्रोडक्ट डेवलप की है और ट्रायल में है?
No, it's not company driven. So these are trials which are done by major institutes. So वो जो there's a CTRI, they're global trials, and in the registry you get in and then they do it. So I think you get into a Google search, type in your the search items, उसमें आ जाएगा the number of countries. Most of these studies are abroad, and in that you can go and see what is the feasibility of you getting into the trial. You can do that.
Thank you. अच्छा मैम, एक चीज़ है कि जैसे I heard about Epstein-Barr virus which has linkages to with MS. So इसका क्या relevance है, and relevance point of view से कि जैसे ये if it is a virus, जो मैंने थोड़ा सा वेब पे देखा है तो इट्स अ वेरी कॉमन काइंड ऑफ वायरस एंड यदि इफ इट इज़ ए कॉमन काइंड ऑफ वायरस इसका क्या रेलेवेंस है एमएस से और यदि ये रहता है हर किसी कॉमनली आ भी जाता है तो इसकी एंटीबॉडीज डेवलप हो जाती है तो एंटीबॉडीज डेवलप होने के बाद फिर भी उसका कोई रेलेवेंस है कि नहीं है और अदरवाइज हाउ वन कैन डिटेक्ट और ये इजीली डायग्नोस हो जाता है कि एमएस पेशेंट में ये वायरस अभी क्या रोल प्ले कर रहा है या व्हाट इज दैट सिग्निफिकेंस इट
So,
हैज
when we talk about causes of MS ना और the risk factors for MS, cause होता है कि आपने पता कर लिया कि ये क्यों हो रहा है 100%. Smoking causes lung cancer, है ना? So in MS the causation is unclear, but there are some associations and risk factors which can predispose you to develop MS or may increase or worsen the disease condition. जैसे इन सब मोस्ट रिस्क फैक्टर्स में से हम स्मोकिंग स्ट्रिक्टली लोगों को बोलते हैं कि आप नहीं करेंगे बिकॉज कहीं ना कहीं पे पॉपुलेशन स्टडीज में उसका एसोसिएशन है फॉर वर्सनिंग MS और बीइंग एसोसिएटेड विद द डेवलपमेंट ऑफ MS. एप्स्टीन बार वायरस जो है वो एक कॉमन वायरस है. उसका सबसे क्लोज एसोसिएशन जो है वो ब्रेन एक कैंसर है लिम्फोमा उसके साथ है, strongest association. So Epstein-Barr virus we all may be exposed. It causes a viral-like illness called infectious mononucleosis, जिसमें glands की enlargement हो जाती है, severe sore throat होता है. But बहुत सारे usual viral infections में हम लोग EBV नहीं कराते हैं रूटीन में, बचपन में, अपने बच्चों का भी नहीं, आप अपना भी नहीं कि आपको वायरल है इन्फेक्शन तो आप EB वायरस करा लो. But ये क्या है कि there are 2-3 viruses which have been suggested to have some association with MS. One of them is Epstein-Barr virus and the other is the chickenpox virus. That also had some studies showing increased chickenpox virus, elements in CSF of patients with MS. Said so, the increasing knowledge about EBV, whether it is causative or it is association, is still not clear. But a recent paper that came in Nature about a year and a half ago reignited the whole concern about EB virus and its association with MS. Yes, future may open up to treatment of EB virus in patients with MS, but there are no specific drugs for EB virus as such.
Oh, okay.
So we really don't know that whether picking up Epstein-Barr virus will lead to change in the treatment paradigms, or maybe we may start focusing more on EB virus as a treatment to instill more cure or maybe instill more risk of worsening of MS. But yes, there is a significant noise about EB virus and MS, but we cannot tell you at this moment that EB virus is the cause of MS.
जो EB वायरस है वो मतलब कोई डायग्नोसिस से पता
सर
चल सकता है
डायग्नोज आप कर सकते हो EB वायरस
एक्टिव है कि नहीं है एक्टिव है ऐसा
सो जब किसी को सस्पेक्टेड इन्फेक्शियस मोनोन्यूक्लियोसिस होता है तो उसमें देयर आर फ्यू स्पेसिफिक टेस्ट व्हिच आर डन टू नो वेदर देयर इज एविडेंस ऑफ EB वायरस. Those tests are available, and then you may be looking for antibodies where you may be only exposed and it may only show that you have been exposed to EB virus. So there are some tests for active disease, there are some tests for exposure to the disease. Both are available.
बट इसका कोई वैक्सीन नहीं है क्या EB वायरस का?
सर एज सच उसका रूटीन वैक्सीनेशन का कोई प्रोसेस नहीं है. देयर इज नो सच प्रोसेस फॉर EBV.
MS का कोई रेलेवेंस गट हेल्थ से भी है जैसे बहुत सारा मतलब
So what we call now the gut microbiome and health, वो itself is a very broad thing. अगर आप gut microbiome को Google करेंगे और neurological causes Google करेंगे तो उसमें MS भी है, Parkinson's disease भी है, dementia भी है, बहुत कुछ है. Yes, there is definitely evolving science in microbiome which is our gut. आप इतना कुछ खाते हैं, इतना कुछ पीते हैं तो gut हमारे अंदर बहुत सारे thousands of bacteria हैं. To know which bacteria is truly needs to be upregulated and which needs to be downregulated, in association with MS. There are few bacteria which have been shown to be promising, but अभी हम उस स्टेज पे नहीं है कि हम किसी स्पेसिफिक ड्रग को देके वो पर्टिकुलर बैक्टीरिया को किल करके एसोसिएशन बनाए. बट हाँ, गट माइक्रोबायोम और MS का इन पैरेलल साइंस में बहुत काम चल रहा है. So we may get some knowledge in the due course.
इस पे कोई मतलब मेडिसिन वगैरह कुछ?
No medicine, sir. No medicine. बहुत सारे लोग हमारे पास आते हैं कि हमने डेयरी खाना बंद कर दिया, मिल्क बंद कर दिया, ये बंद कर दिया. उसका कोई साइंस अभी तक नहीं है, सर. So we only advise good, usual, healthy diet to people. That's all.
Thank you. Thank you, sir.
Good evening, all. So my question was, is bone marrow transplant anyway can be considered as a cure to it, or somebody outside India telling you all those things that...
No, bone marrow transplant is available in India also. It is done at AIIMS also. We've had patients of ours undergoing hematopoietic stem cell transplant. But yes, it is generally reserved for people who are failing one or at least two primary line and secondary line therapies, whose disease is aggressive and is not getting controlled with the even good medications.
So a person who is good on medication is definitely
Not really
recommended
required.
as a cure.
No, that's not the paradigm.
Okay.
Abhi there are ongoing studies to show कि अगर आप highly effective treatment starting में शुरू करते हैं या आप bone marrow transplant straight away करते हैं, दोनों में exactly क्या फर्क है? Those results are also soon. Some part of the results are already there, but some results are going to come. So we will know. क्योंकि अभी हम लोग सबको straight away highly effective treatment नहीं देते हैं, for reasons more than one. Cost, side effects, patient's concern, patients get scared, but yes, there may be a time that we say that we should start directly on a better drug and not on this step-wise approach. वो अभी भी हम करते हैं. अगर कोई patient बहुत starting से ही हमें लगता है कि बहुत rapidly evolving patient है, उसमें करते हैं. But yes, hematopoietic stem cell transplant is definitely a treatment option, and in the right patient can be given as a choice for treatment.
Apart from the cost, sir, you don't advise to normal patients who have just been diagnosed at the
No,
age
sir,
of 20,
no.
23
That's
years?
not yet the paradigm. Because if I tell you that you may have a risk of dying even if it is 2%, I'm quoting the lowest mortality, 1%, 2%. You could go up to 5%. India has many different infections. So I don't think you like to make that decision upfront. So
Thank you very much.
Good evening, doctors. My aunt has been living with MS for the last 2 decades, and she recently transitioned into SPMS last year. And about 3 weeks ago, she was given the booster dose for rituximab. And my close friend is now been recommended to take rituximab. My question is about how can I, as a caregiver, understand how to best support them and how to keep them protected? Because there's one thing that I keep hearing is about how the changes and impacts and implications are there on their immunity or any other body parts. So are there any specific things post-treatment that I, as a family member or caregiver, must keep in mind for them?
So I know who you're talking about. So the thing is that I've told her there's no need to live in a bubble. But you consciously should not be exposed to infections. So rituximab is relatively, more widely used agent. In multiple sclerosis is being given. But beyond MS, rituximab has been widely being used in most dermatological conditions earlier. It continues to be used for a lot of immune diseases, which is not MS. So in fact, we borrowed that science from there to be used in MS. So yes, so what happens in our socio-cultural systems are that you do get exposed to infections inadvertently, and sometimes it is culturally in with us. Somebody बीमार है तो देखने जाना है. तो सोचते हैं ना, बीमार है देखने भी नहीं आया. कहते हैं ना, it is integrated into our cultural system. So that I tell her, avoid it. So don't not get exposed to somebody is coughing, somebody is sneezing, some maid is not well. you even within the system as such, therein you will have to take precautions. I would actually adopt the COVID precautions here. You don't stop living, don't be in a bubble, but at the same time being conscious that you should not be getting into infections. General immunity care, in the sense, like, again, eating good proteinaceous food and being physically and mentally active, which helps in holistic immunity as such. There's nothing really differently special. And be under a follow-up, and there are certain number of blood tests which are to be done at periodic levels, so that the effect of rituximab on certain bone marrow and blood production and liver and other things are also okay. And then the monitoring is also very simple. We're looking at a CD19 count and look at whether you need. And the regimes of rituximab are also pretty varied. And what we follow is one regime, which we are. And then follow-up is what Dr. Rohit also keeps saying, that you need a follow-up. Unfortunately, I know it is difficult. It is difficult to get his appointment more than mine. And then, so therefore, it is difficult to come to an institute, to get into the queues, to wait for people. But it needs to be done at least some point. Like, just don't vanish. And nothing will happen. Relax.
Thank you.
Hi, I'm Diksha. Can you hear me now? Yeah. Hi, I'm Diksha. I'm being treated under Dr. Rohit Bhatia.
Am I on the hot spot or something?
Yeah, you are. Definitely. Yeah, so I have this concern of social acceptability of this disease, as whenever we are talking, maybe in the office or with friends. So, first thing that comes up when someone Googles about MS is that it has to do something with the brain dysfunctionality. And they think that maybe I'm not working as normal as them, or matlab, that lowers down my social confidence.
तो उनको समझाने के लिए मेरे को आना पड़ेगा. ऐसा है कि I think what you need to be more confident first. You need to just feel normal, and I'm sure you are as productive as you were before the diagnosis also. So I think the problem is the myth which those colleagues of you are carrying. Obviously, this is a disease of nervous system. There is no rocket science about it. Saying the rocket will fly in the sky, it has to fly in the sky only, no? So there is no confusion about their Googling and knowing what is MS and that it is a disease of the nervous system. But it is not written that every MS patient is cognitively impaired or functionally, functionally incapable. ऐसा कुछ नहीं है. I think the first thing is that, and we tell this to all our patients who initially come to us, and we open this diagnosis to them, that the first element is dejection. And the dejection is not because they haven't heard this term, because they've already had some priming of this, and they go back and read, and those lines in many of these textbooks and Googles are all about disease which is going to be potentially disabling. All these terms probably need to get modified also, what is written everywhere. So I think my strong suggestion to you as an individual is that you need to be more confident and prove your worth in your work. Let them think whatever they have to think, na? And as clinicians or maybe as doctors, I think it's our moral responsibility also to raise awareness about this problem in the general public. So that's the reason when we do these kind of activities or we try to interact with the press, because that's the strongest medium for people to understand, we do tell them about these elements that they should write so that it creates more positivity in a common person. So I think you just need to be more confident and do your good work. Rest, I, of course, cannot help change mindset of people, but we can always ensure more, myth debunking of these myths in public in general, and that's our responsibility for sure.
That would be of great help. Thank you so much.
Yeah, good evening.
This would be the last question,
yes,
please. Okay? Yeah.
No,
Who?
nobody's behind me now.
Achha.
So, okay, good evening. Namaskar, Dr. Saab, Dr. Padma, and Dr. Bhatia. This is a question on behalf of the society, the people who are suffering legally. ऐसा है कि I have some friends, socially friends also, legal friends also. MS कुछ ऐसा, जैसे आपने भी कहा, बहुत सारे लोगों ने कहा, एक नया वर्ड है जिसको मिसयूज भी हो रहा है. वो कैसे कि कुछ डिवोर्स केसेस हैं जो लीगल फ्रेटर्निटी ने मुझे बताया कि इसका एक सर्टिफिकेट ले आते हैं जो लड़का वाले फैमिली है, और उनका एक जो पहले फिक्स होता है फैमिली मेंटेनेंस, वो आके बाद में दिखा देते हैं जी हम तो इस बीमारी से ये लड़का सफ़र कर रहा है, ये सर्टिफिकेट है, और दे अवॉइड पेइंग द सफरिंग गर्ल, and considering that the court decides, okay, this boy is suffering, so no maintenance post. The court has fixed 20,000 or 25,000 or 50,000 per month. They will say, okay, 5,000, since the boy is not earning, he is suffering from this disease. So what is the solution to that? Because they have MRI, they have some kind of report. They say, the legal people say they managed to get it. What is the solution to this? Suffering young girls.
तो कोई लीगल इश्यूज है तो we won't be able to know about that.
Uska again, is there any solution that they can ask the court to refer to the panel?
I think the courts always do that. हमारे पास बहुत सारे आते हैं for medical opinion. Lot of Supreme Court, High Court keeps sending. A panel बनता है from the MS office. In lots of other cases, even head injury, road traffic accident, certain diseases.
For MS especially because it's as you said also, and they say it's a hidden disease. Slowly it grows.
No, it doesn't grow in everyone, sir. I mean, this is something that requires, I guess, very individualized kind of a decision making. Which
I think in these cases, the council can ask for an opinion from major institutes, and a panel can look into those things.
Because there are examples, there are cases where the boy is very hatta-katta. He's working, unofficially.
No, that's what I'm saying. In a podium.
But he's saying that he's a MS.
What I'm trying to tell you is that these are not medical solutions. And these kind of legal hassles, the council sometimes asks for second opinion, which goes through institutes, panels are made, and these cases can be resolved in those situations.
Okay, thank you.
Good evening. My name is Shrisha. I've been diagnosed with MS last year. There is extensive research being done in MS with respect to stem cell therapy. So, Sir, can you please enlighten us in this regard? Because recently Lewis and Group has published a paper in which they are claiming stem cell therapy as a breakthrough in MS.
So, which stem cell are you talking about?
Hemopoietic only.
Okay, so autologous hematopoietic stem cell transplant, which we call AHSCT, has been a evolving paradigm in MS for many years now. It started with small case series, then individual, different sites across the world started, doing patients, bits and pieces. And then large data sets were published after bringing reports from all these centers, which we call meta-analysis and systematic reviews. All this clearly point to two things. One, AHSCT is definitely one of the most effective treatments in MS. Two, it silences the disease for a long period of time, and you don't need to be on any other disease-modifying treatment. The third, that it causes no evidence of disease activity for a much larger time compared to other medications, but not that everyone who gets stem cell remains disease-free completely. If you follow up patients for 5 or 10 years, a proportion of them will have disease activity, maybe after 5 years, 3 years, 4 years, like that. And the other fourth thing about AHSCT is that it has been associated what we call with treatment-related mortality, or the TRM. And there used to be a data saying mortality up to 5%, 10%. But with these newer conditioning regimens, which are much lesser toxic, because there is a process involved in AHSCT, you have to be given that chemo to wipe off the cells. So those chemotherapeutic regimens have also been evolving to relatively moderate regimens, which may be less toxic, so that you may have a lesser adverse effect. But yes, the treatment-related mortality for younger people, and if done in a proper environment, internationally is even less than 2% or 3%. But yes, you may say on an average anything ranging from 1 to 5%. Said so, AHSCT remains as one of the options, but for patients where you feel that either the disease course is too aggressive, which is not being silenced with the available medications. You've tried at least two good drugs, and the others are either not available or not affordable, or may have same adverse effect profile like AHSCT. So you make a decision that, okay, let's move on to AHSCT. The other thing which I would also like to tell you about that is that it is most effective for active relapsing remitting MS in younger population, but the benefit of it is not as much for people who have progressive MS. So if you are, let's say, advanced SPMS or advanced PPMS, and now you want to say that I want to try AHSCT, it's very unlikely that any transplant specialist will take up your case, because you may have more risk than benefit of the treatment. So we generally talk to patients about this when we see someone with an early phase of a disease or a middle phase of a disease, but we feel there is a potential to respond. Not to someone for the heck of doing it because we have done something very big and we will silence the disease. But as I told you, there is now evolving comparative studies to really say whether AHSCT versus the other more effective drugs can be equally beneficial. Where, of course, I think one deterrent will be the cost and adverse effects, but we are looking forward for publication of those studies to really guide us. But yes, AHSCT definitely is an option for the right patient, and for the right patient can be offered as a treatment.
Thank you so much, sir.
नमस्कार, मेरा बेटा है 25-26 साल की उम्र से एमएस डायग्नोज हो गया, तो ओरल मेडिसिन चलती रही, अब काफ़ी सारे सालों से 8-10 साल हो भी गए होंगे, तो एवोनेक्स ले रहा है एवरी वीक। तो कभी हम मेदांता में गए थे तो एक डॉक्टर न्यूरोलॉजिस्ट ने बोला था कि अगर ये इतने साल से एवोनेक्स ले रहा है तो इसकी नसें सूख गई होंगी। अब वो जब वो चलता है ना, वैसे आगे पीछे ठीक है, हर समय नहीं, ऐसे ऐसे लड़खड़ा सा जाता है, मतलब परेशानी होती है। तो जब शुरू में हुआ था डायग्नोज, तो एवरी ईयर वो एडमिट हो जाता था गंगाराम में, तो उसको स्टेरॉइड के इंजेक्शन्स लगते थे, कभी 3 डेज कभी 5 डेज, तो वो ठीक हो जाता था। फिर जब हमने एवोनेक्स शुरू किया तो ठीक है, उसका जीवन चल रहा है। बाकी डर लगा रहता है कि आने वाले भविष्य में क्या होगा, कि क्या ये डेंजरस है।
मैडम, ये पूरा डिटेल हिस्ट्री समझने के बिना हम थोड़े कंफ्यूज हैं। आप जो स्टोरी बोल रहे हो ना, कि वो स्टेबल है या वो वर्सन हुआ या वो वर्सन होने के बाद दवाई आपने चेंज किया, तो वो थोड़ा सा क्लैरिटी के बिना हम इस बारे में आपको आंसर नहीं कर पाएंगे। बट अगर आप कोई भी मेडिसिन ले रहे हैं और उस पर आपको लग रहा है कि वो स्टेबलाइज हो गया है, तो उस पर रहिए अनलेस आपको कोई साइड इफेक्ट है, आपको लग रहा है उस पर भी वर्सन हो रहा है।
स्टेबल है, थोड़ा सा लड़खड़ा जाता है बस।
वो कोई भी अटैक का इफेक्ट रह भी जाता है ना मैम, अटैक कई बार पूरा 100% ठीक नहीं होता, इसलिए कोई चीज रह गई है वो अलग चीज है, बट कोई खराब होती जा रही है वो डिफरेंट चीज है।
ओके, ठीक है, थैंक यू वेरी मच।
I can take one last question. There was a lady in that sitting in the pink shirt who had come 2-3 times. Yeah, you can come and then we'll finish with the last question.
Hello, sir. Sir, my question was asked by my father only. I just wanted to know. Hello? Yeah. Wanted to know just are there any remyelination happening with the current drug modified therapy?
Someone has already asked
Yeah,
that.
yeah, that's my father only. So
Acha, sir. ठीक
he-
है. That's been answered.
Yeah,
ठीक.
that's
Okay. Thank you.
Thank you.
There is always a natural process of remyelination. That's why you all get better. But
Yes,
there are
there's
those-
research into
those
it also.
treatments are still not in
Yeah.
use, which can remyelinate.
So thank you all very much. It's been late. It's almost 2 hours into it. And so I hope it's been useful. And actually, whoever has still questions and who needs to have any disease modification or have second opinion, you're all welcome to come to the MS clinic on Tuesdays. So we both are there, and you can come room number 1 and room number 7 in neurology. We try to even accommodate patients without any appointments as well. We almost a whole day it runs. In fact, today we had to break because of the awareness program. So stay well. God bless. Bye bye.